Hello, good morning and good evenings. I am Pangyun P.Y. Cho. Today, I'm so happy to see you guys here too. Welcome to ICC webinar today. Today, we are so lucky to have Dr. Cheng-Chun Wu being here with us to give the talk about the velopharyngeal insufficiency. Dr. Wu is the chief of Craniofacial department in Kaohsiung Chang Memorial Hospital. He devoted himself to serving the patient with cleft lip and palate, and evaluated the cleft care and management for better outcomes. As we know, velopharyngeal insufficiency, so-called VI, occurs when the seal between the oral and the nasal cavities doesn't close completely. The condition is often associated with palate defect or genetic disorder. With the VPI, air escapes through your nose during the speech and causing the nasal sound and other speech issues. Treatment usually involves the speech therapist and surgery. So not only the surgery is necessary, so follow will by a series of the speech therapist work that is much more important. So for Dr. Wu's presentation, our today's inviting panelists are both our good friend, Dr. Varun Menon from India and Dr. Ivy Tanko from Philippines. Besides, two more important panelists is our the speech therapist, our teacher Leah and our teacher Ruby. We are so happy to have they both here in our Q&A section later. So let's welcome Dr. Cheng-Chun Wu's presentation. Thank you. Hello, Dr. Wu, please.
Good evening. Can you hear me?
Yes, of course, please.
First, I would like to thank Dr. Zhou's introduction. Dr. Zhou, the two journalists, speech therapists, and all my dear friends and colleagues. Good evening. This is Cheng-Chun Wu from Kaohsiung Chang Memorial Hospital, Taiwan. And first, I would like to apologize that for some reasons I cannot make it get home, so I have to give this speech outside. So it's better. I think it's better if I wear the mask. And today, actually here in this field, many participants are my seniors and my teachers, and I think all have much more experience than me. Today, I will present the result of reviewing the literature, and I will be very appreciative to have comments, teachings, and corrections of my mistakes if there is any from all the participants. Although the title today is velopharyngeal insufficiency, I would like to start from velopharyngeal dysfunction. In the later slide, I will introduce and make the definition clear. Velopharyngeal dysfunction is an active function of dynamic structure, and they work to control the velopharyngeal sphincter. It could be a structural abnormality or neuromotor abnormality, or even behavioral abnormality. And regarding the velopharyngeal sphincters, they are composed of some muscles, including the uvular muscle, palatal glossus, the lateral veli palatini, tensor veli palatini, and also the palatal pharyngeus and superior pharyngeal constrictors. The main function of velopharyngeal sphincters and manipulate air and sound from the respiratory tract into intelligible speech. The flow of air between oral and nasal cavity. And when we have to do the speech, swallowing, vomiting, blowing, and sucking, we it separates oral and nasal cavity. When we approach the patients of velopharyngeal dysfunction, it should be managed by a multidisciplinary team and by multimodal instruments. I think we all agree that the speech language pathologist or speech therapist should be the most important key characters in this treatment. Because it's very important to distinguish velopharyngeal sphincter dysfunction and behavioral speech dysfunction, which give us the information that the patient just need a speech therapy or patient's speech therapy with surgical intervention. And the velopharyngeal dysfunction could be divided into 3 categories from the paper published in 2017. Could be velopharyngeal insufficiency, and velopharyngeal incompetence, velopharyngeal strain. Velopharyngeal insufficiency is related to insufficient tissue or mechanical restriction, which in the velopharyngeal insufficiency may have more relationship with our surgeons. Means the condition might be changed or improved by surgery. The green part is related to the part, including velopharyngeal, including velopharyngeal insufficiency resulting from impaired palate and post-impaired VPI, palatopharyngeal disproportion, and compensatory misarticulation of oral nasal fistula. This green part is related to patients of impaired palate. Oral nasal fistula is classified to no velopharyngeal dysfunction. And the other two, velopharyngeal competence, is lack of neuromotor competence. Velopharyngeal mislearning is related to maladaptive respiratory habits. And the patients in these 2 groups are mostly not candidate for surgery, speech therapy, and care more. First, in velopharyngeal insufficiency, it will result from impaired palate, including some mucus palate, or post-impaired velopharyngeal insufficiency, which is reported about 20 to 30% in the literature. Post-impaired velopharyngeal insufficiency is possibly due to surgical scarring and misalignment of the lateral platini or creation of a palatal fistula. And the risk causes include palatopharyngeal disproportion and clinical interference, such as tonsillar hypertrophy, causing poor sphincter mobility. And as for velopharyngeal competency, it's beyond the top figure, I think. And it can mainly be divided into dysarthria and hypoxia, congenital or acquired. Dysarthria is the weakness or lack of control in the speech muscles. Patient may have central nervous disorder or paralysis of the face. And for hypoxia, the speech muscle is fine, and the patient is failed to communicate between brain and speech muscles. The patient are aware of what to say. So the patient of dysarthria show a consistent error, while the patient of hypoxia shows a consistent error. For velopharyngeal mislearning, it could be a compensatory misarticulation. In fact, all patients with an anatomical cause of velopharyngeal dysfunction may present with a compensatory misarticulation. It develops spontaneously to reduce the intraoral air pressure and persist even after mechanical repair. What we have to do is to distinguish this mislearning misarticulation, which results from normal use of velopharyngeal mechanism. Now, obviously, forming a specific nasal air emission belongs to this category. Here,
Excuse me, Cheng-Chun. I cannot hear you very clearly. Can you close the microphone too? Yes. Thank you very much.
okay, how about now?
Yeah. Okay. Thank you.
Okay.
Yeah. Okay.
Okay. So here I would like to speak about nasal air emission first. Nasal air emission is an audible visible nasal air emission. Here is the most familiar velopharyngeal feature producing air pressure constant. It could be detected with the assistance of a neural air under the nose. Nasal air emission is an obligatory distortion of the air with abnormal structure. At that time, the patient has normal articulation, such as velopharyngeal insufficiency, and the patient may develop compensatory articulation. And forming specific nasal air emission is a persistent nasal air emission even after the anatomical repair, only in a specific misarticulated sound. So the recurrent misarticulation, the forming specific nasal emission. Recurrent misarticulation could only be corrected by speech therapy. And finally, we also have to pay attention whether the patient has hearing impairment or not. This is also the cause of velopharyngeal mislearning.
Hello. Computer is shut down.
Yes.
Okay. So would you like to restart your computer? Okay. Okay. So you can come in back again, Dr. Wu. Yeah. Okay. We're waiting for you. Oh. Yes. No problem. So I think our panelist, Dr. Velopharyngeal and Ivy is now online with us. I will have one question for both the panelists. What is your usual surgery for the patients with the cleft palate? And how is the incidence of the patient to have the VPI afterward in the age of about 3 to 5 years? So the first question I would like to check with Dr. Mellon. So I would like to know your opinion. Thank you.
Thank you. That's a very interesting question, and which I am very much keen. I've been following up my palate patients for years. What I believe is like we can't do one technique for all palates.
Yes.
If the length of palate is very good and you have adequate muscle, say like good quality muscle, our conventional palatoplasty works well. That is what I mean by conventional palatoplasty is with interveloplasty, radical muscle dissection. But if the length of the palate is not adequate enough, then you need to modify. Then you need to evaluate whether the furlough works. But there are limitations with furloughs as well. So then comes more of lengthening with buccal flaps. So that is my take-home message to all palates is one technique can't be practiced for all palates. But then the question is of learning curve and incidence of fistulas, there's no room for error. All these come into play. So as a surgeon, your first and foremost is like to give a palate which is without any fistulas, but which is giving a decent speech outcome. Okay.
Good. I got it.
So when you evaluate over years what is working in your hands and stick on to it, and then there is always room to improve with the speech correction surgeries.
Great. Okay, thank you for your comment. Okay, let's proceed with the Dr. Cheng-Chun. Yeah, no problem. Yeah, okay, please go ahead.
Sorry for some problem with the computer. So when in diagnosing velopharyngeal dysfunction, there are some methods and examinations. The first is perceptual speech analysis. And we have some tools, including so it's a video, nasopharyngeal endoscopy, and multi-view speech video fluoroscopy, and objective nasometry or MRI. And in perceptual speech analysis and speech language pathologists to assess the resonance pattern, or how we mentioned previously, abnormal, audible, or visible nasal elevation, whether the patient with maladaptive industrial or facial fluency, whether the patient with misarticulation or not. And the perceptual speech analysis will be used as a physical weight speech scale for the recorded PWSS. The resonance is the sound moves and reverberates through the vocal tract. It is assessed by voice sound, including vowel and consonants. When there is an abnormal closure of velopharyngeal sphincter, it results in increasing vocal redundance through the nose, and it causes hypernasality. When we do the analysis, we have to pay attention, especially in overpressure sounds, means plosives, fricatives, and affricatives. Before we go further, I would like to give a very short introduction about the consonants. And actually, this is not my profession, but usually when we face the patient in the clinic, sometimes the surgeons still have to ask the patient to speak. So what I give is only a basic concept. And if there is any mistakes or any comments from the speech therapist, I would be very appreciative. The consonant is called the member, and it can be classified by whether the consonant is very thin or not. And also it can be classified by manner of articulation and place of articulation. And we're talking about the voicing consonant, and the vocal fold may be held against each other, adjust the right tension, so that the airflow past them will force them to vibrate against each other. In this process, the sound will be made. And there are paired and unpaired voice and voiceless consonants in English. And actually, in a paired group, it doesn't mean that it is physically impossible to say a sound of the counterpart. It is simply that the English has chosen not to use such sound instead of
Excuse me, Cheng-Chun. Would you like to hold your microphone like me to very close to your mouth? That probably will be more clear for the audience. Thank you.
Okay, sorry.
Yeah, thank you very much. Because a lot of background in your environment is always bothering. Thank you very much. Yes.
How about this?
Yeah. Okay. Okay. Great.
Clear?
Yeah.
Clear?
Yeah. Okay. Let's
Okay,
get.
okay. So it's not clear. It's clear. And by means of articulation, talking about the relationship between the articulators, the consonant classified as stop, fricative, positive, fricative, and vocal. And the stop consonant is completely cutting off the airflow through the mouth. When the tongue tip touches the bridge, cuts off the airflow. It could be a nasal stop, also called nasals, like the sound, which involves airflow through the nose, and oral stop, also called the plosive, like tail, which has not airflow into nasal. Check the plosive in Mandarin, like a bao. And talking about the fricative and approximate, the fricative in Mandarin is the mocha. In fricative, the articulators involved in the constriction approaches get close enough to each other and to create a turbulent air stream. So there are lots of fricatives in English. And in approximate, the articulators involved in the constriction are further apart still. And they are for a fricative, and therefore it will not become turbulent. And there are four approximate in English. And for a fricative, it's a single sound composed of a stop and a fricative portion, like in English. And this sound is first interrupted by a stop, which is very similar to tail. And the articulator become like a fricative to cause a turbulent air stream later. And for the later, you have to pay attention to what you are doing when your tongue, when you say the first consonant.
Yeah. Excuse me, Cheng-Chun.
Yes.
Can you take away about the mask, or is not allowed for you to take off the mask? How about no? Yeah. Yes.
Is it clear?
Yeah, yeah, much better.
Okay. Please. Okay.
Okay.
可以马上。这样听得到吗
Yeah, yeah, okay.
Okay. Okay. The letter, and when you say the first consonant, it's L. Actually, the later side of tongue drops so that the air can pass through this drop area. So more specifically, a letter should be a letter approximate. And if the consonant is classified by test of articulation, it is specified by where the vocal tract the narrowing occurs, means the tubules occur. There are lots of places of articulation, including this is a bilabial, it's an upper and lower approaches to each other. And the labia dental, the lower lip approaches to upper teeth. In dental, the tongue will approach to upper teeth. The alveolar tongue will approach to the alveolar ridge just behind the upper teeth. And post-alveolar, the tongue will approach immediately behind the alveolar ridge. In vitro flex, the tongue is curved backward in the mouth, like a word. In the palatal, the tongue will approach to hard palate. The tongue will approach soft palate or the belly. The glottal sound is it's an opening of glottis and it's narrow enough to create turbulence. Okay, so we get back to the perceptual speech analysis. In addition to redundant pattern and abnormal audible or physical nasal emission, we can also assess whether the patient has adaptive nostril or facial grimacing or not. The facial grimacing is a compensatory action used to narrow external nails to decrease nasal air emission in non-nasal speech. And in addition to perceptual speech analysis, there are a lot of tools we can use to help us to diagnose these patients. The first is video nasopharyngeal endoscopy. It's performed by a speech language pathologist. And the speech language pathologist will guide the patient and through repetition of a standardized speech sample. It could provide the information and direct visualization of a degree of velopharyngeal closure and position and function of the lateral musculature and length and quality of soft palate, and also the degree of motion of lateral pharyngeal. And these are some photos in the paper we published last year of some closure pattern, different closure pattern and different closure ratio in the video nasopharyngeal endoscopy. 没办法，又给我卡住了，对不起。
So now your slide is stuck, right? Okay.
Yes.
So I have another question for Professor Fayyaz. Hello, Professor Fayyaz. As we already invite you give two very important lectures, some very difficult cases of very difficult big defect of palate. So I am wondering, how is the speech function after you repair so difficult wide palatal defect in your series? Could you give us some introduction or instruction? Thank you very much.
Thank you very much, Dr. Peng. Whenever we repair a wide cleft palate, the tissues are quite short, and after wide radical dissection of the pedicle, we can close the palate. But literally, the palatal tissues are quite short, and most of the wide cleft palate, they usually end up with VPI. And in my presentation, I also showed that we did pharyngeal flap in 5 of those patients. 5 out of 25 patients. But okay, I'm not sure the VP competence about the other patients, because some of the patients, they don't come back or they live in far-flung areas. But most of the wide cleft palate, I had a personal feeling every wide cleft palate would ultimately develop velopharyngeal incompetence.
Okay. Thank you very much.
And
yeah.
For every velopharyngeal incompetent patient, we have a policy that we send the patient to our speech pathologist. He will examine the patient. He will examine the speech sample, and then he will guide us that the patient is VP incompetent and the palatal length have to be increased. So our policy has been, we always go for pharyngeal flap, and we have a policy that we do not take more than 60% of the width of the posterior pharyngeal wall. So we want to leave two holes on both sides, 20% and 20%, so that the patient does not develop obstructive sleep apnea. So that's our policy. We have done probably more than 400 or 500 pharyngeal flap in the last many years. We had obstructive sleep apnea only in 3 or 4 patients.
Yeah, okay, thank you, appreciate. And one question for Ivy. Yeah, hello, Dr. Ivy from Philippines, how are you?
Hello.
Oh, thank you for your joining.
Good evening.
Hi, long time no see. Yeah, for the velopharyngeal insufficiency in your team, do you have like a speech pathologist in your team to evaluate all the patients that with the cleft palate in your long-term series? So can you give us experience how you work with your the speech team? Okay, thank you.
Okay, actually for our institution as of now, because we are at the northern part of the Philippines, actually we don't previously we hired a speech pathologist, but then recently they shifted to other courses. But for patients with velopharyngeal insufficiency, we usually refer them to private clinics already. And for the law, actually, I cannot really say much about the outcomes for the speech of our patients, because once they go to the private clinics, they usually cannot come back, first because of the financial capacity of the patients. And secondly, they usually come from provinces. But for patients with velopharyngeal insufficiency, for the reconstruction, we usually do furlough as much as possible, repeat furlough palatoplasty to still close the gap or the fistulas. And afterwards, they would have a better speech outcomes with furlough.
Okay, yeah, got it. Thank you very much.
Thank you.
Thank you. So now we come back to our presenter, Dr. Wu. Would you give us probably 5 minutes about a short introduction about your treatment for the VPI? Yes, please.
Okay, thank you.
Thank
so
you.
much. I'm so sorry.
No, no problem.
Okay, and there are a non-surgery and surgery treatment for these patients. And for non-surgery, a long-time prosthesis could be a temporary or permanent solution for the patients with surgery. And also the speech therapy is necessary for velopharyngeal miscellaneous or even the patient with velopharyngeal insufficiency after the operation to correct the circulation. I think the surgery is a main topic today. The surgery could have some goals, like compensate the poor function by narrowing the velopharyngeal sphincter, such as posterior pharyngeal flap, sphincter pharyngoplasty, or augmentation of posterior pharyngeal wall. And also it can correct the muscle function by palatal repair with repetition of the beta venipunctum, or the both like double opposing T-plasty as both functions. The posterior pharyngeal flap, since it was introduced in 1865, it became one of the oldest and most commonly used method, and it in a muscular mucosal bridge between the soft palate and the posterior pharyngeal wall. It divided by a velopharyngeal sphincter into two smaller ports, and also by need adequate mobility of lateral pharyngeal wall to close the two lateral ports. It may provide a benefit to patients with such or circular closure pattern. And this photo shows the posterior pharyngeal flap. And there are some debates in posterior pharyngeal flap whether it should be a superior or inferior phase. whether it should be split the pattern with midnight or not, whether it should be like the flap with nasal mucosa from soap pattern or not, whether it should be performed through a full dissection of soap pattern or not. But we know the posterior flap has the risk of obstructive sleep apnea. Actually, in the literature, it was only 5.3% relative complication rate. And also, it's reported that for some patients of obstructive sleep apnea, even after we take out this flap, the patient still has no velopharyngeal insufficiency, which means the posterior pharyngeal flap has a longevity improvement of speech. Talking about the sphincter pharyngeoplasty, is an innovation of significantly orientated posterior tonsillar flap, including palatopharyngeal muscle, and a transposition of this flap is 90 degrees to the ventral position against the posterior pharyngeal wall. And the picture shows the sphincter pharyngeoplasty. And actually, the big complication is obstructive sleep. It should be informed the patient and the parents. And the augmentation of posterior pharyngeal wall is a long history. And recently, the experience of autologous tissue like fat or cartilage is more, but actually a lack of conclusive data and long-term outcome. And also, complication is possible, such as fat implants. So, further studies the palatable repair is a limitation of the muscle is actually advocated for initial straight-line laproplasty or insertion of it's paired with further laproplasty without intravenous. But both methods emphasize the correction of abnormal position of the and the suture of the light into the muscle plate. Also, in this process, we can remove the scar tissue. The couple of plasty is a widely used, effective, and safe method to lengthen the plasty of both nasal and oral mucosa. And it can be orientation of the velopharyngeal in greatest degree of covenant under functional tension. And also a pharyngeoplasty effect through major velopharyngeal sphincter. This photo shows the classical double plasty. And in this process, also to set whether the double plastic should be performed with or without veloplasty. Actually, in the literature, there is no different conclusion. And I think the surgeon comfort to produce the best result. So I think I can start.
Okay, yeah.
Because the later slide is another paper.
Okay, yeah, okay, no problem. So I think I would like to have all the questions for our presenter, Dr. Wu, and our panelist, Ivy and Melon, and we have a speech therapist as well, and give you a question here and to be answered by our professionals, please. So now I think I have one question to ask our speech therapist. Hello, Tianxiang 老师, can you hear me? Hello.
Yes.
Oh,
yes.
Thank you very
Can you
much.
hear me?
Yeah, of course. Okay, now online with us is our teacher, Claudia. I would like to ask Claudia, what is our treatment principle? For example, you would like to recommend the furlough surgery or pharyngeal flap surgery for VPI. What is your criteria to suggest that for the surgeons? Yeah, could you tell us? Thank you very much.
Recently, I'm preparing for the foreign, and it's exactly about the same topic of the VPI.
Yes.
And from my point of view, I think the primary palatoplasty is the most important thing.
Yes.
So when you can perform an excellent palatoplasty, the VPI rate can drop to below 10%. I think that helped a lot.
Mm-hmm.
So from my viewpoint, I do see the effect that furlough Z-plasty is very effective.
Mm-hmm.
And as for the secondary treatment, that really depends on the previous palatoplasty.
Mm-hmm.
If we are lucky to have a good palatoplasty for the primary palatoplasty, usually another furlough or just redo furlough can just fix the problem. Unless they have some syndrome associated, they have the hypotonia, like the VCF syndrome, then probably sometimes the pharyngeal flap will be better. Does that answer your question?
Yeah, it's good. So what is your preferred age of the patient to receive the secondary palatoplasty for the VPI? Yes.
Usually we try to fix their problem before 4. That's the previous protocol.
Okay.
But recently we found out if their articulation condition is okay, we will probably delay to the age 9 because we will have the bone graft surgery at that time.
Okay.
So probably we will combine together.
Okay, sure. So after the alveolar bone grafting. Okay, great. Thank you very much.
Thank you.
Thank you. Yeah, so Claudia is one of our speech therapists, and I would like to ask our another speech therapist, teacher Ruby. Are you here with us? Yeah, so hello, Ruby. Can you hear me?
Hello.
Hello, yeah, nice to hear your voice is here. Yeah, so Ruby is one of our teacher here. So in Chang'an, what is our most evaluations tools to do and to check the patient's speech functions? So can you introduce to us? Thank you very much.
Actually, right after the primary palatoplasty, that we will see the patient at around 2.5. That's the time that they have completed their speech development.
Mm-hmm.
Then after that, if our patient are at risk for VPI, probably we'll see them every 6 months.
Mm-hmm. Okay.
But if they do have good speech development, then we'll see them in every 2 years.
Mm-hmm.
That's kind of change since I entered the center. It is because that, just like Claudia has mentioned, that because we have done pretty good with the primary palatoplasty, so speech person doesn't have to see the patients that often.
Okay.
So that saves some time. Yeah.
Mm-hmm. Mm-hmm. Mm-hmm.
That's
okay.
it.
Great.
Thank you.
Yeah. Thank you very much. So in your experience, I think not all patients with the speech problems is in a very young age. So in your experience, how the oldest patient you can treat probably the speech problem in your practice years. So could you give us some recommendation? Yeah. How
The
old?
oldest?
Yeah.
The oldest?
Yes.
As long as they want to improve their speech, they can come at any time.
Okay.
The oldest one we see is at around 50.
Okay.
Yeah. Since they are willing to come. Yeah.
Okay.
66.
Thank you.
Thank you very much. Thank you, teacher Ruby. Okay, let's bow back to Cheng-Chun. Hello, Dr. Wu. Are you here? Yes. Okay. So yeah, I think I can invite our panelists to give you some comment. Okay, so first of all, I would like to invite Dr. Melon. Do you have any comments for Dr. Wu's presentation today? Yes, please.
Yeah, this was one important slide which Dr. Wu has projected. It is a surgeon comfort that will produce the best result. The surgeon who is sometimes some people will be comfortable with the radical muscle dissection. For some it's primary furloughplasty. So most of the palates will work with the technique that surgeon is comfortable with. But sometimes the wide cleft palate, which Dr. Professor said, what happens in wider clefts is like it automatically reduces the length of the soft palate. So in those conditions, automatically or invariably results in BPI. So those are the clefts which ultimately requires a speech improvement surgeries later on. And just like our speech pathologist said, Claudia and Ruby, we have 3 dedicated speech pathologists in our unit. So after the primary palate repair, they tend to give an overview to the parents of how to go forward with the speech therapy sessions. And hearing also an important thing. Sometimes they might need a ENT intervention before or later on. So both hearing and speech definitely needs to be looked after the primary palate repair. So one is technique of primary palatoplasty and frequent speech therapy consultation. Both results in the outcome of how the speech develops later on.
Yeah. Okay. Thank you. Okay, and our the panelist Ivy, do you have any comments for Dr. Wu's presentation, please? Hello, Ivy. Can you hear me? Okay. If not, may I invite Professor Low to give us comment to the Dr. Wu, please, Professor Low.
For the management of BPI, if the patient had cleft palate repair before and developed BPI, we usually ask our speech pathologists, Claudia and Ruby, to evaluate the patient. First, speech perceptual evaluation, and then move to nasopharyngeal scope for the so-called instrumental evaluation. Then we decide our treatment protocol if the patient have so-called the marginal BPI, and then we do furlough double protein Z plasty. If the patient have moderate to severe BPI, then we may consider pharyngeal flap. I would emphasize that when we decide to use pharyngeal flap, we need to use it cautiously, because pharyngeal flap is not a comfortable procedure for the patient. Patient always feel something foreign body sensation in the throat, and reduce airway passage. So usually we very carefully do the pharyngeal flap. But if the patient is required and we need to talk to the patient for the use of pharyngeal flap. So this is our current protocol, and I think our success rate treating the BPI is quite good. It's quite acceptable. I do have question to ask the audience. I think many of you are from a situation that you may have unrepaired cleft patient, older patient. Okay, they definitely have BPI when they comes to you. For example, 5 years, 6 years of age, or even older. What do you do for the cleft palate repair? Do you do a primary cleft palate repair, or you do any, for example, Velo or 2 flap plus pharyngeal flap? What is your protocol?
Okay.
Dr.
Yeah, Dr.
Dr.
Mellon, please. Yes.
Yeah, that's an interesting question. Sometimes we find adult palates completely untouched, speaking so well without any nasality. So that is a mystery.
Yeah.
But if the speech is poor, the primary palate repair will be the conventional technique of palate repair. And then we evaluate how the speech evolves over a period of time. And if later on, if any speech correction surgery is needed, then we'll go about with it, provided the patient is willing to attend regular speech therapy sessions. So that is one important factor, whether the patient is able to attend speech therapy sessions before and after your corrective surgeries.
Okay, I'd like to ask one by one. Dr. Ivy, what is your opinion?
Okay, the protocol for our hospital, if we get a patient with VPI, we evaluate them first if the defect may be still repaired with furlopalatoplasty first. And because in our practice, it is believed that, of course, the reapproximation of the muscles is the one that's really important. And then if afterwards, if the repair is still non-functional, then that's the time we do, for example, pharyngeal flaps or buccal flaps, and that's when we refer the patient to the speech pathologist after about 6 weeks after the procedure. So that's the step-by-step.
No. My question is that if a patient, for example, 6 years of age, comes to you unrepaired cleft palate, so you will do a primary repair only, right?
Oh, yes.
So if the cleft palate is very wide, you still can manage to close the cleft palate with velopharyngeal.
Yes, we still do furlopalatoplasty even at that age.
Okay. Okay.
Yeah.
And Dr. Fayaz, what is your opinion?
Yes. Actually, we had a randomized study where we made 2 groups, and all of these patients were 6 years or more. The palate was not operated, so we made 2 groups. In one group, we did Bardak 2 flap palatoplasty, and in the other group, we added a pharyngeal flap at the same stage. And we followed the patient, and our speech pathologist was blinded. He did not know that this patient had Bardak palatoplasty only, or the pharyngeal flap has been added. So he examined the speech sample, and the findings were, when we add the pharyngeal flap in older patient with the primary palate repair, the speech results are much better than when we do only palate repair in older patients. So, and this paper was published in Annals of Plastic Surgery in May 2019.
So do you recommend that for the older patient, you will do 2 flap plus pharyngeal flap?
Yes, we always do. We always do in older patients.
Yeah, because I feel that it could also be 2 stage, meaning that the first stage we do the palate repair, and then we wait for a period of time and then do the evaluation and decide what will be the VP procedure. Then this will be 2 stage. Certainly, if you do it 1 stage, the palate repair plus pharyngeal flap, the speech outcome should be better. So I actually do not know which protocol is better. Bernie, what is your idea?
Yeah, actually, when I got back from Taiwan, I had a deluge of older patients, because before the year 2000, there was a protocol wherein anybody older than 12 years old, they were relegated to obturator. So when we got back, our oldest patient of primary palatoplasty is actually 36 years old. So, and our protocol right now that we use is we do primary palatoplasty first, then wait 6 months to 1 year of intensive speech therapy, then do a nasopharyngoscopy, and then from there we decide whether just a furlough or a pharyngeal flap or a furlough with a pharyngeal flap. So it's a furlough and a pharyngeal flap in one operation. Yeah, and of course, when we evaluate our patients for speech, it's a multidisciplinary setting. So I am the surgeon, the dentist, and the speech therapist is there. And we have to segregate the speech problem because is it an articulation issue or a velopharyngeal insufficiency issue? If it's a velopharyngeal insufficiency issue, then the speech therapist will do the nasopharyngoscopy, and we can plan whether we do just a furlough or furlough plus pharyngeal flap. If it's an articulation issue, then I discuss with our orthodontist, do we need alveolar bone graft and orthodontic treatment, and later on plan the orthognathic surgery. So whenever we see patients, especially older patients, we tell them you're a little late for the surgeries, but if you stay with us and stick with us, we can hopefully give you a good speech. Because the patient with the 36-year-old patient was finally able to graduate from college because she couldn't pass because of the speech issue. So yeah, when talking about pharyngeal flap, my other issue here is I've been getting pharyngeal flap done by other individuals, other surgeons, and the pharyngeal flap is set too low. So it's such that the pull of the pharyngeal flap is downward. So whenever I talk with my residents, I tell them when you do a pharyngeal flap and you can see it on physical examination that it's too low, you have to be at the C1 level. So I think that's a big factor, because I've had a lot of patients who have really bad speech and they already had the pharyngeal flap. So what to do next? Because the pharyngeal flap is set low. It's pulling the palate downward instead of upwards. So yeah.
Okay.
Claudia or Ruby, can you answer the question?
About which one?
Oh,
there are many questions in yeah, waiting in line. So
I think the last question Bernie asked is that if the pharyngeal flap is setting the pedicle is too low.
Too low.
Too low.
What can we do?
I think we have recommended several cases that the pharyngeal flap is too low to either revision or just, I don't know how you make it, but you have done that.
Can you
before.
still dissect the pharyngeal flap to a higher position? I haven't tried that. Would it still be viable?
I don't know.
Well, usually I would divide the pharyngeal flap and I do a new one with the higher pedicle. Yeah, otherwise it's difficult to move a low pedicle to move it higher to the to the C1 level, unless you divide the whole pedicle and get a new pharyngeal flap. That should not be difficult. So back to the question that for the older patient with BPI and unrepaired cracked palate, I think certainly Dr. Fayyad's prospective study doing one stage, which is 2 flap plus pharyngeal flap, is the result is better. In terms of the speed, result is better, because if you do only primary repair, the very high chance you need to do a secondary procedure, right, Dr. Fayaz?
Yes. Our protocol has been, when we do the palate repair along with pharyngeal flap, we will dissect the levators on both sides. And then in the nasal layer, we will add the pharyngeal flap. And then both levator will be sutured together at the base of the pharyngeal flap. So both levators will give some dynamic function to the pharyngeal flap. That's why the speech improved considerably in our group of patients where we added palate with the pharyngeal flap. This is very important.
Okay. Yeah. So now we have some. Okay, Berna. Yeah. Yeah.
Oh, I just last maybe comment about the pharyngeal flap. I always want to reserve the pharyngeal flap as a last resort, because sometimes the patient with a furlough can have a very big improvement of speech, especially if the initial surgery had a lot of scarring. I've already performed a lot on patients where the scar is as bad as a burn contracture, like similar to a burn contracture, that I had to cut the scar. The only thing I could think of is there are some surgeons who use a lot of cautery when they do the palatoplasty, and maybe this is a factor. So with the release of the scar, the speech improvement drastically improves. So I usually tell them pharyngeal flap last resort only. Last resort. Yeah.
Okay.
That's it.
Okay. Okay. Thank you.
In one of my patients, the patient came from other city. He already had sphincteropharyngoplasty done by another surgeon, but the gap was too wide. I divided the sphincter. I raised the pharyngeal flap, and the patient's speech improved considerably. It also depends upon the expertise of the surgeon to do good pharyngeal flap.
Okay. Yeah. Sounds good. Okay, so we have some questions from our participants. So I will answer our panelists one by one. The first one is according to Dr. Wu's presentation, Dr. Spudi want to know the experience with prosthesis, the pharyngeal obturator, and the palatal lift. So our expert here is the experience you have the obturator in your practice. Yeah. Or I would like to ask our teacher Claudia, do you have any experience to deliver the obturator for the patient with the patient problems, kids? Yes. Yes, Claudia, please.
We have the obturation for patients with not really the VPI, but more like alveolar cleft to occlude the oral nerve fistula, so they have enough intraoral pressure so they can speak much better. And
yes,
yes, yeah, we do have a successful case. He just had the pharyngeal, but yes, just the obturator to obturate the oral nerve fistula. Then he developed quite well speech.
Okay, good. Yeah. So for the next question is from. Okay. Yeah, Professor Low.
I would like to add some comment regarding the obturator or palatal lift. Because in Chang'an we did palatal lift before, but not recently. In my memory, I didn't see anyone using a palatal lift. Okay, but because if we have patient with VPI, we try to solve the problem with surgical intervention so that it is long lasting and it avoid the dental condition, because if you use obturator or palatal lift, you have to you have to attach to the the dentition. But if you have patient that really could not receive surgical intervention for some reason, for medical reason or for whatever, then I think a good solution will be the obturator, nasopharyngeal obturator, because again, we do not have much experience in this regard. But in one meeting, I heard a lecture from a doctor from Brazil. He is a dentist. He did very wonderful job using a dental appliance, a palatal appliance, and then use obturator and adjust the obturator inside the nasopharyngeal space very well. And the patient have very good speech using the obturator. So I think it will be up to your team, your center, or if you have a dental colleague who have very good skill to use the nasopharyngeal obturator, then it should be a good solution.
Okay. Yeah, one of our participant has the comment on the obturator in the lip. Yeah, please go ahead. Can you turn on your audio? The name of an iPhone.
So you have to switch on your voice.
Yeah, okay, I got you. Yes, please. Yes, please.
Yeah, hello. Can you hear me?
Yes, yeah.
Yeah,
please.
I had a question.
Yes.
How easy is it? Well, two questions. Number one, how easy is it to do a Z-plasty on a patient who already had a successful Z-plasty, and what's the logic behind it? And the second question is, in theory, when you do a pharyngeal flap, almost all the time are the muscles are sewn to the flap element. And so why would the way they described it as doing a primary pharyngeal flap, anastomosing the muscles to the flap, any different than what you normally do?
Yeah. So, Dr. Fayaz, would you like to give the answer, please? Yes.
I can answer the second part. Although, the scenario would be of two types. In a patient where the primary palate has been operated previously and the palate looks short, and then we will add a pharyngeal flap, and sometimes the palate is so much scarred that we are unable to find the levators on both sides. So in that case, we will simply split the soft palate. We will add the pharyngeal flap in the nasal layer, and then we will bring the oral layer at the base of the pharyngeal flap. However, when we can see the good amount of muscle on both sides, whether it is a secondary patient or we are operating an older patient with 5 years or 6 years of age or more, we will dissect the levator on both sides. We will add the pharyngeal flap in the nasal layer, and we will bring the muscle from both sides at the base of the pharyngeal flap. I do not have any group comparison, but our feeling has been when we put the levator at the base of the pharyngeal flap, the speech improvement is much better than when the levators are lying away from the pharyngeal flap. This is our strong feeling.
Okay.
I think I can answer the first question regarding initial primary Z-plasty fellow double opposing Z, and then secondary we do double opposing Z again. We call it redo fellow double opposing Z. To do that, we design the same regular, like that is big Z, and then and then all the dissection follow the same the same principle. That is the mucosa muscle part push back, in nasal side and oral side, this is the reverse, and then push backward the mucosa muscle part. In this way, the muscle repair actually is not horizontal, actually is more backward to the uvular area. I think if you are interested, you can check. I published an article talking about reduced Z-plasty, double opposite Z-plasty.
Yeah, okay. So Dr. Venom, do you have any comment on these two questions? Yeah, please.
Yeah, initially when we discussed about pharyngeal flap, I'm still skeptical about using it for primary palate repair. And we, like Bernard said, we would like to reserve pharyngeal flap as a last resort. So we stick with the conventional, be with the primary technique or the furlough Z-plasty, and then monitor the patient with speech therapy, evaluate with the speech pathologist and the nasoendoscopy how much the gap is. Just like Professor Lowe described, whether it is a mild gap, moderate gap, or a large gap, then you need to evaluate what your technique of repair should be. Whether you need to incorporate a furlough Z-plasty to improve the length of the palate, or incorporate a buccal flap in place, or you do a conventional pharyngeal flap to lengthen the, to give an anatomic closure. So that's what I feel should be your mode of tackling your VPI.
Mm-hmm. Okay, good. Yeah, for the further questions from Bernie, Bernie is asking about the class patients or has the class 3, the malocclusions. So what you expert, you are planning the surgery and to preserve the VP function. So Professor Lowe, yes. Please demute. Professor Lowe, you are muted.
Okay, I don't think I have the plan to do OGS and then preserve the velopharyngeal function, but instead we call it, this is the final stage of evaluation. Okay, if patient have a class 3 malocclusion, that will require OGS. Patient have residual oral nasal fissura. Patient have video flow velopharyngeal insufficiency. Then I will do evaluation and I will have 2-stage plan. The first stage is always orthodontic surgery plus orthodontic treatment. And then 1 year later, we started second stage. That will be a velopharyngeal operation, with or without closure of the oral nasal fissura, with or without nose and lip revision. So that can be the second stage. We always do the bone surgery in the first stage, and then the soft tissue operation in the second stage.
Mm-hmm. Okay. So do you have others, the expert have the different opinion on these questions? Okay, so let's proceed to the next questions. So the next question is from Dr. Ezianochi. Is it possible to have good speech outcome with older patients? So do you use the same strategies in speech therapy for young and older patients? Yes.
I think the speech will improve.
Mm-hmm.
When I was being trained in 1980, I was told that if we repair a cleft palate beyond 4 years of age, there will be no benefit because the speech has become fixed in the cerebral cortex. But over many years, we have observed, if we do good palate repair, by good palate repair, I mean, if we do good levator dissection and transposition posteriorly as near as the uvula, the speech will improve considerably. The speech would improve considerably. So I repaired a primary palate patient at 47 years of age back in 2007. and I can understand the speech of that patient even on cell phone. So speech will improve. Only thing, there may be articulation error which needs intervention by a speech pathologist.
Okay. Yeah. Thank you, Fayaz. And our teacher Claudia, in your speech therapist, do you have any different strategy for young and or older kids? Yes, please.
I think I would invite Ruby to answer this question because she has more experiences in patients with.
Okay.
I'm not sure how old is older patients.
Yeah. Okay. Hello, teacher Ruby. Are you here?
Yes.
Thank you. Please.
That's the same question for me. That
Yes.
I don't know how old is old,
Okay.
but actually, when we are providing speech therapy, we try different ways. It really depends on the ages to tell them the placement of the articulation. So technically, we do not change, but in nature, it's because they are old enough. They can kind of listen to the rules. So that's the difference in terms of the attitudes and in terms of materials.
Yes.
And that's my answer to that. Yeah.
Okay. Thank you, Ruby. Yeah.
Okay. Can I give some comment here?
Yes.
I think for the regardless of age, I think I would do the same planning for the VPI, unless patient have different concern. For example, if they are afraid of nasal airway obstruction, then we try to avoid pharyngeal flap or narrow the pharyngeal flap in order not to cause respiratory obstruction. I think if patient wish to correct resonance, I think we can do surgical intervention to improve the hypernasality. However, the articulation is difficult to correct. I think it depends on patient's training. For the older patient, really it's not easy, but maybe Ruby and Claudia can answer this question. However, we do have a patient who, in Taiwan, moved to US. He started to speak English, and he can actually very good articulation in speaking English. So maybe a second language can can improve that.
Okay.
Actually, I agree with Dr. Low that about the second language, introduction of second language, but we do that just for all kinds of ages, because when we are teaching them the second language, actually we are teaching them the new concept of articulation. So after we introduce English, and then we kind of compare that to our Mandarin Chinese. So that will facilitate our patients to carry over to better speech. That's the maybe that's the technique we have been approaching to our patients, either in younger age or in older age. That works a lot.
Thank you, Ruby. And I know Bernie has some comment to give. Yeah, please.
Yes, sorry. Yes, whenever I see the older patient, so what we term in our center as older patient is around 12 years and above. We always tell them that, yes, you will have an improvement in your intelligibility, your resonance will improve, your oral hygiene will improve because no more food will come out. Well, less food will come out of your nose. And but of course, they have to make sure that they are really realistic when it comes to their expectations. We'll tell them it will be very difficult to reach 100% that you have no speech problems or no VPI or no articulation disorders, but definitely your speech will improve. And the second portion is we tell the parents that a factor here is the child's motivation to change their habit, change their speech, do speech therapy, because we've seen children who are very well motivated despite having surgeries quite late end up with very mild insufficiency. But we have patients who had their surgeries done early and very, very poor motivation, doesn't like to go to speech therapy, and a lot of articulation disorders, articulation issues. So big factor, expectation and maybe patient motivation. So
okay,
I can say.
Great. Yeah, so it's very connect to our next questions. Yeah, from Professor Handa from Japan. So I think it's a question is for our teacher Ruby and Claudia. So what is the criteria to consider persuade the patient to receive the surgical intervention instead of the non-surgical treatment? Yes. Hello, Ruby. Thank you.
Let me read the question.
Okay. So, yeah.
Okay. What do the criteria to consider surgical intervention? My understanding of this question is that when we first perceived got the patient, and we will make the decision that if there is the necessary for the nasendoscope, then primarily Claudia and I have decided that this patient might need a surgical intervention. But under the nasendoscope, or when we are doing our perceptual assessment, we found that there is some stimulability, which is very important for a speech person to consider that there's possibility for our patient to avoid the surgery. When I talk about stimulability, it means that although there's some insufficiency on the BP function, but the patient still had chance to acquire good articulation, then probably we will think that we will postpone the surgery, or probably we just proceed to the speech therapy, the behavior management alone. So it's kind of because of the patient's ability and their performance on their speech output to lead us to make the decision and to make the recommendation.
Okay.
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 You.
Very good. Yeah. Thank you, teachers. Any comments from other experts in our panel?
May I add one thing? I think. Oh, sorry.
Yeah. Okay.
Okay.
Sorry.
Claudia first. Yes.
I just add one thing that whenever we think that surgery will help the child to speak better, we will go for surgery. That means the problem comes from physical condition. Okay, that's.
Okay, got you. Okay, and the Manon, please.
Yeah, these are two important points, one by Bernard and Dr. Ruby. The motivation of the patient to attend speech therapy. That is one factor, whether it be primary or speech correction surgery, whether the patient is willing to attend speech therapy sessions determine your outcome as well. And an interesting point which Dr. Ruby said, you need to assess the speech as well as see via nasal endoscopy how much the gap is. how much the VPI is. If the corrections, whatever correction is possible can be corrected by the speech pathologist, then the only option is speech correction surgeries. So that is one way to motivate the patient that now the corrections are all done. Whatever the speech pathologist can do has been done. Now the only option is surgical intervention. Okay. So that's one way to tell the patients for speech therapy correction, I mean speech improvement surgeries.
Sure. Yeah. So our next question is just exactly what you're concerned. So what the next question is that from the Dr. Huang Hui-Fen, Dr. Huang, how can you decide the width of the pharyngeal flap, narrow or wide in primary palatal-plasty in adult patients? So Professor Low, do you have any experience in adult patient? Yeah.
Okay, when I repair adult patient primary palatal-plasty with pharyngeal flap, I usually raise about middle width of the pharyngeal flap. That is enough to close the nasal side. So, and I mobilize the two flap to the oral side. So that's my width of the pharyngeal flap. I would rather hear Dr. Fayyad's opinion.
Yes, we have a very fixed policy. We do not go beyond 60% of the width of the posterior pharyngeal wall, because if we increase the width of the we increase the width of the pharyngeal flap, we are increasing the risk of obstructive sleep apnea. So we always limit the maximum size of pharyngeal flap to 60% of the width of the posterior pharyngeal wall. And rest of the issues can be handled by speech therapist. And we do not end up with any patient having obstructive sleep apnea. That's our routine policy.
Okay, good. Okay, so I think the final questions, okay, from Bernie. Yeah. Does age, yes, the age problem, does the age of the patient become a factor in deciding furlough versus the pharyngeal flap? Would you perform a pharyngeal flap in a young patient less than 9 or 10 years old? Yes, please. Maybe Professor Fayyaz.
Yes.
Yes, please.
Actually, we usually do 2 flap palatoplasty, and I would do furlough rarely, but I will do furlough in secondary patients. So if the patient is 9 or 10 years old and he has not been operated, we would, as a policy, we will add pharyngeal flap in the primary stage. But if the patient has been operated previously, we would go for a pharyngeal flap. Maximum width would be 60%, and the speech will improve provided the levators have been dissected from both sides and they are put in the midline at the base of the pharyngeal flap. This factor is very important.
Okay. Professor Dr. Venon, your comment?
And more than the age, I would still differ how the closure happens in determining the technique of PPI correction. Whether it is a circular closure, whether it is a transverse, whether the posterior pharyngeal wall needs to augment, or whether the lateral walls are moving well, whether it is short palate. All these factors have a more determining role in your type of BPI correction rather than age of the patient. Of course, age also matters, just like how I said. I would still defer the pharyngeal flap to an older child rather than a younger age group.
Okay, good. So I would like to invite the final comment from Professor Low. Yes, please.
I think tonight we discussed several methods treating the VPI. I think mostly we talk about furlough for the soft palate lengthening and muscle rearrangement. and or we do a pharyngeal flap, which has a bigger effect to close the nasopharyngeal gap in order to reduce the nasality, hypernasality. However, we should not forget other procedure, because if you look at the literature, there are so many different kind of velopharyngeal procedure that is happening. Okay, even individual surgeons have their preferred technique. For example, even fat injection to the posterior pharyngeal wall or to the soft palate, or and also recently they are more and more popularly used buccal myomucosa flap to lengthen the soft palate, and then use the flap to close the anterior part of the soft palate. So, or also use a pharyngeal flap that is not a traditional way of pharyngeal flap, use so-called insertion, many kind of different modification of pharyngeal flap, or even sphincter pharyngoplasty. I think the key point is that if you're a surgeon, if you're familiar with using a single technique or two technique, I think if you use it with experience and you got a good result, that is very nice. So do not need to follow, any other suggestion. But the point is that you can achieve a good result. And also do not forget the nasal airway obstruction is always an issue that you need to keep in mind. Do not, try not to induce obstructive sleep apnea. I think this is a good idea that when you do the velopharyngeal management. And also a good speech pathologist is very important. That I know that some of you do not have the fortune as us, that we have a very good speech pathologist to work together. You may, as a surgeon, you may need to manage to listen yourself, or you may even need to do the nasopharyngeal scope yourself. That is also good. I remember when I was young, Dr. Nodov asked me to perform nasopharyngeal scope. I surrender. I cannot really do a scope in a 4 years old child. Really difficult for me. So if possible, I think speech pathology is very important. I think in your society, you can try to make good friend with your speech pathologist, and that's also is a key point.
Thank you, Professor Low. Yes, so I think time is very delayed now, so I would like to invite all our participants to show you your screen, please. Yeah, in the beginning, I apologize for the video conferences. The audio is not so good, yeah, and I apologize also for our presenter, Dr. Wu, is in the not good environment to deliver this very important speech. However, I think that's why we have more time to have very comprehensive talk and discussion afterward with so many experienced experts. Thank you, Professor Fayez. Thank you, Professor Low. Thank you, our panelists, the Mainland and the IV, and thank you, Bernie's comment too. And thank you all the questions from the Professor Handa, yeah, as well. And especially thank you for our Chang staff, very important to speech therapists. Hello, Claudia and Ruby. Don't be shy, please show your smile. Hello, Claudia and Ruby. Okay, so finally, I would like to take a group photo with all of you. Yeah. The same, I will count to 3 and give me a triumph or give me a heart. Okay, 1, 2, cheese. Thank you very much. Okay, good morning and good evening, and thank you for your joining today. And I hope we can meet together for our very important master course in November with the Professor Somerlade and the Professor Hopper in November. Looking forward to seeing you again. Have a nice day. Bye-bye. Thank you. Bye-bye.
Thank you.
Bye-bye.